Okay, so good morning everyone. Today I'll be talking about the previous experiences and outcomes that we have had in the past 4 years. So, coming to a chronological evolution for the entire program, it all began in 2018, where we conducted a CME with difference at Kanpur. Then it was moved on to Uttarakhand State Ophthalmic Society, and an exercise was conducted at GSVM Medical College, Kanpur. Then we went on to a national level at Gurugram, and then even through the COVID period, we conducted some online surveys, and we went on to the virtual AIOC. And right now we're presenting this course again in the AIOC Mumbai. So how it all began? So first there was a reality check, that is artificial intelligence accessibility possible in the setting of our nation when there are so many rural areas and remote setting places. So actually it is very difficult that AI can reach those areas. And then the need for evaluation of AI for purpose of identification of treatable DR. So what Dr. Malay said previously, that is a machine actually required for such a thing when anyone can do it, which WHO also says. So we need to teach the general ophthalmologists the identification of treatable diabetic retinopathy and simplify the procedure of identification. So in Kanpur Ophthalmic Society, in CME with a difference, this was to set afloat the program which was conducted with general ophthalmologists of Kanpur Ophthalmic Society, and all the consultants were initially educated about the basic pathologies in diabetic retinopathy. So participation was done by all the consultants, and they were asked to fill a survey form. And the only question was that would you treat this condition or not? And the initial response sensitivity ranged from 55% to 75%. The target audience age group was 40 to 80 years. And we had a positive response. So this enlightened the entire team to move ahead and embark on a journey for the same. So next step was Uttarakhand State Ophthalmic Society in 2019. So encouraged by the previous feedback, an introductory program was conducted in this Uttara Icon, and this was a growth of event to a state level rather than a city level program. So this was again well appreciated by the audience there, and this again gave a positive outlook to the entire team. So now we needed to ponder on ways to enhance our program. So then we conducted it in an exercise in Medical College, Kanpur. So this time the participants were ophthalmology residents in training. So the idea behind conducting this exercise was that if success can be achieved at this level, then when ophthalmologists in training can be, pursued to give a positive reply, why not the general ophthalmologists who are experienced and well trained can also be introduced to this concept. So the ICO classification for diabetic retinopathy was introduced, and there was display of random images. So there were 20 students who participated, and all were shown 10 slides to pick. So the simple options were again provided, which was to treat or should we do a no treatment policy. So this time the sensitivity increased to 80%. So this showed that we are currently on the right track and we should move ahead. So what's next? The next is time to make some decisions regarding how should we move ahead. And then we need to identify a referral threshold. So this is a very important thing, that when we need to know that we need to refer this patient or not. And we need to standardize the concept and then present this entire thing on a mass level. So then we decided to present this topic in the All India Conference in 2020. And this was the first time that this concept was introduced at a national level from our side. So in an instruction course, we told about the basic features of DR first, and voting pads were provided to the entire participating audience, and on-spot voting was conducted. So the goal was to conduct an interactive session and obtain live analysis behind our entire thought. So this was the sample image, and everyone was asked a question, for instance, that is this a picture of retina or not? And they were given 3 options from which they had to choose. So the basis of the course was that vision-threatening diabetic retinopathy features were chosen, And rather than clinically significant macular edema, diabetic macular edema involving center or not was taken up, which is according to the recent ICO guidelines. So the training was done in 2 steps. In the first step, simplified photographs of DR was shown to everyone, and the voting was conducted, where everyone had 30 seconds for a response for each slide. So the responses of everyone was recorded, and random selection of this strata was done to mandate participation. So this was the sample slide that was presented during that course, and everyone was asked a question and they were given options. The answer wasn't displayed at that time. But afterwards, this was the result which took place after the live voting was present and the answers were recorded. So similarly, I have couple more slides for the same sample that was conducted at that time, and voting was done. So after this first session of voting, the interpretation was that the responses were erratic in nature and everyone had a state of uncertainty and doubt. So after this, the step 2 included introduction of basic criteria of ICO, pictures of certain disease patterns like macular edema, vitreous hemorrhage, NVD, NVE. These were shown. VTDR characteristics were taught, and then again the process of showing photographs and on-spot voting was repeated, and the results were recorded. So after this, we can clearly see that the entire population who was answering, this time they had 60% rate of sensitivity who had correct answers, and only 20% had wrong answers. However, there were 20% population also who had divided. They were divided between yes or no. So on random selection and voting, it was observed that there was a predictable outcome. The mandate was very clear in clear cases. So we needed to upgrade the decision-making capacity of the general ophthalmologist. And there was moderate sensitivity rate in borderline cases. So what we learned, that our reference threshold should be VTDR, which is vision-threatening diabetic retinopathy. The target audience should be general ophthalmologists and not specialists. The limitations of AI were demystified over time, and the objective scope of human analog was better identified. Then we conducted a random online survey of DR for Geo, which was done in May. So a random survey of the study was conducted via online Google Forms, and the response of 23 ophthalmologists were recorded. So this was the sample form which was put up online. And again, the images were displayed, and we had the question that does the image show VTDR features? And options were given, yes, no, or can't say. So similarly, these were the options, and the responses were recorded again. So there was a similar response that we conducted in an IC, even on the online forum. So decision making was very clear-cut, accurate, hence the education of general ophthalmologists for further management should be done. In borderline cases, answers were still divided or doubtful, therefore the moderate sensitivity prevailed. Again, an online survey was conducted in the month of November 2021. This time, however, the responses were recorded of 100 ophthalmologists instead of 23. So this was done on a larger scale, but however, again, similar responses were recorded. So human analog in current scenario, it is analog which we have considered against the artificial intelligence as a screening tool for diabetic retinopathy referral. So it is used to combat the load of diabetic blindness in our nation and availability of prompt services even in the remote parts of our nation. So this is the voting pad that today also you all will be provided, and you can use the numbers 1, 2 and 3 to answer as yes, no or can't say. So thank you so much, and I'd like to invite the next speaker.